Hi, Miss Nikki here. Welcome to part 2 of the urinary system. We're going to look at the transport of several nutrients through the nephron. We're going to do an overview of this transport process. So we're going to look at how they can be transported and the items that are transported. I don't want you to get too into the weeds about this. Here they're talking about paracellular. This is the transport between the epithelial cells that are in the tubules, and then transcellular. So you're actually moving a substance across. So trans, moving across, para, next to. So here, just to make sure we know where we are, this is the glomerulus, this is the glomerular capsule, and we're here in the proximal convoluted tubule. So here are the epithelial cells of the tube, and we can see the filtrate is moving through the tube. All they're showing you is that some solutes, some substances are going to be able to move between the interstitial fluid and the tubular fluid just by squeezing between the epithelial cells. And some ions and some solutes are going to have to be transported. So they're going to have to move in through some sort of carrier protein, and then they're going to have to be exchanged into the interstitial fluid by some sort of ATP process. So kind of, the very simplistic, are there both passive and active ways to transport solutes from the tube out into the interstitial fluid? Yes. And then hopefully we're going to reabsorb these substances back into the bloodstream. And hopefully we've made the connection that if I'm anywhere in the PCT or DCT, that's the peritubular capillary. Remember down here we have the vasorecta capillary. First, let's start with substances that should be completely reabsorbed. So glucose transport. We're going to see that into the tubule cell, hopefully we're thinking epithelial lining of the PCT. So these tubule cells are going to transport sodium and glucose through proteins, and the energy from moving the sodium is going to use it to move glucose the opposite way. So secondary active transport is what we call this, and then we're going to see the glucose return to the peritubular capillaries into the blood plasma. So 100% of glucose should be reabsorbed in healthy individuals. Here we can see high sodium, so the sodium moves in, and that allows glucose to move in. And then glucose now is transported from the tubule cell of the proximal convoluted tubule into the interstitial fluid and then into the actual peritubular capillary or into your blood plasma. So 100% of glucose should be reabsorbed. So what does that mean if you have high glucose in your urine? Probably means something's wrong, right? We're not transporting enough glucose. Your cells are not absorbing enough glucose. So if you have super high concentrations of glucose, I think fasting is below 100 after a meal, maybe 160, 50, something in that range. So what happens if your blood, so I'm saying plasma, but I'm talking about blood, right? Blood plasma glucose concentration is high. You're going to start excreting glucose in your urine. And glucose pulls water into the tubular fluid, and this comes out eventually as urine if it doesn't get reabsorbed. So the glucose is acting to pull water into the tubular fluid, so that increases your urine production. And the loss of fluid in urine is going to make you thirsty. Your cells are thirsty, right? We need more water. You can see that sodium reabsorption is close to 100%. The majority of sodium reabsorption happens in the proximal convoluted tubule. It's relatively high in the interstitial fluid. We're also going to see sodium-potassium pumps. Remember, this is active transport and requires ATP. We're going to see these working to move potassium and sodium in the opposite direction. And we're going to see reabsorption regulated by hormones, aldosterone and atrial natriuretic peptide. This image is showing you that sodium is reabsorbed along the way through the tube system, but that the majority of sodium reabsorption is happening in the initial section, which is the proximal convoluted tubule. We're going to get into a little bit more detail about what's happening to sodium and how we're setting up a sodium concentration gradient when we start talking about this nephron loop. Here we can see the movement or transport of sodium. So they're talking about high sodium moving into the epithelial cells of the PCT, and that this is going from high to low. And then we're going to have the sodium potassium pumps here. Remember, these are moving from low to high concentration, and then it'll be reabsorbed into the bloodstream. So again, what are they trying to show you? They're trying to show you that we have both passive and active ways to transport sodium from the kidney tubule into the interstitial fluid and then into our bloodstream. And hopefully we're thinking about the fact that we have to have a resting membrane potential. So all of our muscles and all of our neurons, in order to set up this resting membrane potential, muscles was -70, nerves -70 millivolts. We have to have sodium on the outside and we have to have potassium on the inside. Water reabsorption is going to happen by transporting water between the cells, and then we're also going to have that transcellular where it's actually going through the cells. We filter a lot of water, but we're going to reabsorb the majority. We really only eliminate about 1.5 liters of water. So it says all but. The majority of water reabsorption happens in the proximal convoluted tubule, and remember that water follows sodium by osmosis. So hopefully by now we're seeing, okay, sodium, if it gets reabsorbed, it also, glucose gets reabsorbed, also water gets reabsorbed, and then remember potassium does the opposite because of that sodium-potassium pump. In the previous slide, we talked about how water can make its way between cells, so that paracellular transport, and then we said water can cross cells with the help of aquaporins, and that would be that transcellular here into the interstitial fluid and then eventually be taken up into the blood plasma. I put this particular image here so we can see the collecting tubule and the collecting duct. Remember ADH, which hopefully we're okay with. ADH is on or being released. We're going to see an increase in water absorption. So here they're showing you that ADH hormone is binding to the cell and it's causing an increased production in aquaporins. So the more aquaporins I have, the more water is able to be reabsorbed. In the nephron loop, we're going to see water reabsorbed. In the collecting duct, collecting tubules, distal convoluted tubule, we're going to see water reabsorption controlled by aldosterone and antidiuretic hormone. Remember, aldosterone is going to cause sodium to be reabsorbed, and then water is going to follow. Antidiuretic we just looked at causes an increase in aquaporins, and then we have an increase in water reabsorption. So go back and look at aldosterone and antidiuretic hormone. We can see in this image, I just thought it was nice to kind of go back and look at the fact that about 65% of water is reabsorbed in the proximal convoluted tubule. We are going to have some reabsorption of water in the nephron loop, and then dependent on hormone function, ADH and aldosterone, we might have more or increased water absorption happening in the collecting tubule or collecting duct. I put this slide in because I want you to kind of make the relationship or connection between ADH and aldosterone and what's going to happen to your urine. So if ADH and aldosterone are on or being released, you're going to have increased water reabsorption. So hopefully we got that. What does that mean with urine? So if you're reabsorbing more water, your urine is going to be more concentrated. You're going to have higher solutes, right? And you're going to have lower water because you reabsorbed all of the water. So what's going to happen to your urine? It's going to be more concentrated. It's going to be more yellow, or if you want to say darker in color, that's fine. So what happens if these hormones are off? You're going to have more water being released, so less water reabsorbed, more water in your urine. So you're going to have high water, low solute concentration. You're going to have less concentrated urine, and it's going to be lighter in color, white to pale yellow. Reabsorption and secretion of potassium. Wanted to make sure that we know this is dependent on the movement of sodium. So sodium is reabsorbed, water follows, and potassium is going to be excreted. So they're going opposite ways. So I know I've said this more than once, but I do think it's important. Potassium is going to go the opposite. Here we can see the majority of potassium is reabsorbed in the proximal convoluted tubule. You have a little bit happening here in this ascending section of the nephron loop, and then it's going to be regulated by hormones, right? So depending if aldosterone is on or off. Hopefully we're seeing calcium and the phosphate, and we're automatically thinking bone. If you remember hydroxyapatite, parathyroid hormone controls both of these. And I'll show you on the next picture kind of what's going on. But if you remember, parathyroid hormone is released if blood calcium levels are low. Remember, calcium is needed for muscle contraction, nervous cell transmission, so one neuron to talk to another. So we need to have increased blood calcium levels, or enough blood calcium floating in the plasma. So parathyroid hormone is released. If blood calcium levels are low, that's going to stimulate the reabsorption in the distal convoluted tubule. Parathyroid hormone regulates both calcium and phosphates. And usually, like I said, these two together make bone. But if I'm trying to increase the calcium ions in my blood, I don't want it to go and be stored as bone. So you're going to see that the majority of phosphate makes it through as filtrate, and there's less calcium that makes it through. So parathyroid hormone is a little tricky. It stops the reabsorption of phosphates and increases the reabsorption of calcium, so that these two are not together going to create bone. Instead, it'll just cause the increase in calcium in the bloodstream. So now we have to go back to the bicarbonates and talk about those again. Can we regulate reabsorption or secretion in the kidneys? And will it affect pH? So go back to this equation. So looking here at the bicarbonate and the hydrogens, could I reabsorb either one of those? Put it back into my bloodstream? Yes. Could I also cause increased secretion? Could I move either one of these ions out into my urine and get it out of the bloodstream? Yes. So what they're saying is that the kidneys also have the ability to regulate pH by either reabsorbing these ions or secreting these ions, and it will affect the overall pH of your blood. So first thing, if your blood is acidic, so that would be high hydrogens, lots of hydrogen ions. The real simple way to fix this is to secrete the hydrogen ions as urine, right? Just push them out into your urine. And then we go from high to low. Well, another way that we could do this is we could reabsorb the bicarbonate. So what happens if the hydrogen ions that we have in our blood get recombined with this bicarbonate that our kidneys are reabsorbing? We're putting more bicarbonate back into the bloodstream. Those two combine together, they can form carbonic acid, they can drive the reaction backwards, and we can exhale the hydrogen ions and water. So did we remove the hydrogen ions? We can either directly remove them by secreting them in the urine, or we can reabsorb the bicarbonate knowing that it binds to the hydrogen and drives this reaction, and then we can exhale this unwanted hydrogen ion. This is going to cause an increase in blood pH. So your blood was acidic. Your blood is going to increase in pH number. The number is going to go up, and your blood's going to be less acidic. This is also going to decrease the urine of the pH. For alkaline blood, what can we do? If we have alkaline blood, the pH is too high, right? It's above the 745. We could either secrete bicarb, which bicarb makes your blood alkaline, so we could secrete that, get rid of it. That would be like the direct route. Or we could reabsorb hydrogens. The hydrogens will bind to the bicarb that's in the blood that's making it too high, and then we can drive the reaction backwards and exhale. This is going to lower the pH. Remember, the blood pH is too high, it's alkaline. We're going to lower the blood pH, and we're going to increase the urine pH. Also, we have to eliminate nitrogenous wastes. So any sort of metabolic waste from the breakdown of proteins or nucleic acids, urea, protein breakdown byproduct, uric acid, nucleic acid breakdown product. Creatinine, this is from creatine or creatinine metabolism. If you remember, we talked about creatine phosphate, and we said that during muscle contraction, we'll steal this phosphate, add it to ADP, so that we can generate quick temporary ATP until we can start breathing enough oxygen to do cellular respiration. So these are 3 common nitrogenous wastes that are in urine. And lastly, here we can see the elimination of certain drugs if we're taking antibiotics, if we're taking aspirin for a headache, any sort of hormone metabolites as they're breaking down, any other hormones, epinephrine, adrenaline. So all of these also have to be secreted, and the majority of that happens in the proximal convoluted tubule. Now I have to talk about establishing a concentration gradient. This is a little bit difficult. Hopefully the next image, as I walk you through it, will make a little bit more sense. But remember, if we're moving sodium and water, this is all happening because of the concentration gradient. Remember, sodium moves from high to low if we're talking about passive. So sodium's going to move from high to low, and water's going to follow. And we have to set up this concentration gradient if we're talking about passive transport. We do have some active transport where we're going against the current, right? That sodium potassium pump. That's when we're moving from low to high. We need ATP, that's active transport. So I'm not really talking about this right now. I'm talking about this passive transport, setting up a concentration gradient so that we can force the movement of fluid. And it gets a little difficult because they're talking about 2 different sections. So we're going to see how the nephron loop is going to help establish the gradient. So we're going to see sodium chloride being pushed out of the nephron loop. And then we're going to see this concentration gradient maintained, and we're going to see the interstitial fluid pushing items into the vasorecta capillary. So this is called the countercurrent exchange. So let's go to the image and we'll talk about it. Okay, let's look at the countercurrent multiplier. So you see here the tubular fluid, everything in blue is interstitial fluid, and then we have our blood vessel here. When we're talking about the countercurrent multiplier, they're talking about increasing the concentration. So there's less concentration of sodium chloride here, and there's more concentrated sodium chloride here. And what are we looking at? We're looking at cortex to medulla. Remember, this loop, nephron loop, goes down into the medulla. So kind of as we're moving this way, we have more salt concentration. So that's what they're trying to show you with the blue and the white. So we know if we have items in the tube, we have this tubular fluid, and we want to push it into the blood vessel, we first have to put it into the interstitial fluid. So it's always going to be tubular fluid, then interstitial fluid, and then eventually the concentration gradient will force the movement of objects into the blood vessel. We'll talk about the vasa recta in just a second. Right now, I just want to focus on the fact that as the descending limb is permeable to water, so we're moving water out here, but we're not moving salt. It's impermeable to salt. So what's happening is the water's moving out and it's concentrating the tubular fluid. So there's more sodium chloride in the tube as it makes its way through the loop. In this ascending limb here, it's permeable to salt and impermeable to water. So we have just concentrated, just by having this loop, we push the water out on one side, we concentrate lots of sodium chloride in this loop of the tube, and then in the ascending, we're going to push out into the interstitial fluid lots of sodium chloride. So we are changing the concentration gradient. Another thing to think about is after you do DCT, you're also going to have your collecting duct here. And remember, the collecting duct allows for water to be reabsorbed. Well, why do you think the water is moving towards the high salt concentration, right? We do have hormones that are directing this, but we're creating this high salt environment in order to reabsorb the majority of our water. So we've created high salt, right? High salt concentration on this side, and there's water on this side. And now we're going to move from the interstitial fluid, we're going to exchange water and salt depending on this concentration gradient that we just set up. The fact that there's more sodium chloride here and there's less here. So these two systems allow us to passively move sodium and water across this membrane and help us set up this concentration gradient so that we can move those items into the blood vessel. Basically reabsorb. So if we didn't have these systems, we'd have to drink a lot more water. We wouldn't be able to reabsorb the majority of the water that we reabsorb. So we're basically, the first step is we're setting up a salt concentration so that we can do the second part, the exchange part, where we actually bring the salt back in or we bring the water back into the blood vessel. If we wanted to look at kidney function, we could run a renal plasma clearance test. There is a plant derivative called inulin, and they use inulin because we don't make inulin. It should be filtered out by the kidneys. So it's a whole calculation. You can measure the plasma clearance of this substance. So we inject you with it and we see how long it takes for that substance to clear, and we look at whether it's equal to your normal, or what would be a normal glomerular filtration rate. So if for some reason that substance is being reabsorbed, there's something wrong. Something's wrong with kidney function, and it probably means that you're also reabsorbing other substances that you shouldn't, like ureas and uric acids. If someone's in renal failure, there are varying levels you can see from diminished to absent, meaning 0. And this is a chronic disease, lifelong. There's something wrong with the glomerulus. Could be from an autoimmune disease attacking your nephrons, could be from high blood pressure. We've kind of talked about the fire hose on your kidneys or on your nephrons would be bad. It could be diabetes, lots of glucose in your blood, and it's going to damage that glomerulus filtration. Once it's destroyed, there is no regaining function. So you cannot regrow a kidney, at least not right now, right? So the only thing we can do is do external blood filtration. So dialysis, we hook you up to a machine and we filter your blood. Basically, this is an external kidney. Or we can do a kidney transplant and we can implant another kidney that is functioning into your body. So for right now, we need to be nice to our kidneys because we have no way to regenerate them. Now that we're looking at the characteristics of urine, hopefully we've got the definition. We know that urine is the product of filtered and processed blood plasma. It is basically filtered blood plasma. Your textbook says that it's sterile unless it's contaminated with microbes. This is being called into question right now. There's a lot of new research, and they're saying that urine is never really sterile. Composition, what is urine? Mostly water, a little bit of solutes. This is kind of the big takeaway that we usually see are the nitrogenous wastes. We're also going to see some hormone breakdown, ketone bodies. If you're processing fats instead of sugar, you're going to have lots of ketone bodies. If you want to look at all the normal solutes that could be in your urine, please feel free to look in the book. So we average about 1 to 2 liters of urine a day. Obviously, variations with fluid intake and blood pressure and temperature and any other diuretics or drugs that you're on, if you have diabetes or other fluid excretion. So this obviously is an estimate. Normal pH between 4.5 and 8. More acidic with larger amounts of protein in your diet. Less acidic if you have lots of fruits and veggies. Influenced by metabolism. So your T3, T4, right? Thyroid metabolism, increase, decrease urine production. And obviously, if you have an infection, that's going to get in the way of normal kidney filtration. Specific gravity, they're just talking about density. So basically saying that urine has a higher density than water. I know it's 95% water, but those 5% solutes make the density a little bit higher of urine than water. Color, clear to dark yellow, depending on concentration. And the smell. Normal urine doesn't have a terrible smell. If the urine sits for a while, the ammonia starts breaking down due to bacteria. And that's when you start having that smell, that ammonia strong smell of urine. And then in diabetes, because glucose uptake is not happening in the cells and the muscles, or it's not happening as much as it should, that you're going to have a lot of glucose in the urine. And so it'll smell a little bit sweeter. Urinary tract is composed of the ureters or ureters, the urinary bladder, and the urethra. The ureters are going to take the urine from the kidneys and deliver it to the bladder. This is retroperitoneal, behind those peritoneal membranes. This originates from the renal pelvis and exits the ileum of the kidney. So if you remember, we had the ileum and we have the minors. The minors drain into the majors. The majors drain into the renal pelvis. And then we have our ureters or ureters. They want to just show you the 3 tunicas of the ureter. There's a mucosal layer, a muscular layer, and an adventitia. And if we're kind of following everything we've talked about, the mucosal is always going to be an epithelial lining of some sort. If you remember this transitional epithelium, we talked about it a lot in the bladder, or at least we mentioned that was where you find this kind of rare epithelial type. Muscularis, obviously, we're going to have some layer of muscle. And then we're going to have adventitia. This is the outer layer, lots of fibers, some connective tissue. And we've seen this same setup, mucosal on the inside, muscle in the middle, some sort of more fibrous tissue on the outside. So the ureters project through the bladder wall. They're kind of at an angle, obliquely. They decrease, because of this, the way that they enter the bladder, they decrease backflow. So while you're emptying urine, we do not want urine to backflow into the ureter or go back to the kidneys. And then they want to make sure that you understand that these are innervated by an autonomic nervous system. So remember sympathetic, fight or flight. Hopefully we know sympathetic is going to decrease urine production. And then parasympathetic, which is rest and digest, is going to increase urine production. Just to give you an idea, here's that fibrous adventitia. Then you can see the muscular layer here, and then you can see the mucosal layer. So here is the transitional epithelium, good at stretching and recoiling. And I just wanted you to see that the lumen is pretty small. So the opening for urine is not a large lumen that maybe we're used to with blood vessels like arteries. Urinary bladder, this is expandable. It's a reservoir for urine. We're going to store urine here. It is also retroperitoneal. So here they want you to know the bladder is more triangular shaped when it is empty, and that the urine as it fills is going to kind of dome or round out the top a little bit. It becomes a little bit more oval. There is a specific area, this trigone, and it's where the ureters or ureters and the urethra meet. So kind of a pyramid inside of a pyramid, or inverted pyramid inside a pyramid. This area is common site of infections, bladder infections. For tunicas this time, we're going to have a mucosa, a submucosa, a muscularis, and an adventitia. So you can see the mucosal layer, transitional epithelium. We have a submucosal area. Usually this is going to be connective tissue, like areolar connective tissue. Then we have a muscularis. This is going to have smooth muscle, right? Hopefully we're okay with smooth muscle is involuntary. That was from 201. This is where we're going to see the internal urethral sphincter. And then we have this outer layer of connective tissue. Again, more of a fibrous region that offers stability. So here you can see adventitia. We're going to have blood vessels. More of an outer coating, and then we're going to see the muscularis, and then we're going to see that submucosal connective tissue, and then we see the transitional epithelium. Again, you can see the bladder can kind of round out the top here, and I think this is a nice image to see that trigone area. You can see they don't show you kind of the fact that the ureters or ureters are entering right here, but that's what those little openings are. And then we can see the urethra is here, so you can see kind of the pyramid inside the pyramid. So the urethra, this is an epithelial lined tube. It is going to exit the bladder through the urethral opening. It's going to expel urine from the body, and we're going to look at these two sphincters. So the internal urethral sphincter, it is involuntary, it is smooth muscle. It's going to be at the neck of the bladder. And then we have the external urethral sphincter. This is controlled by skeletal muscles, and this would be voluntary. So remember, skeletal muscles, you have to have the nerve send the message to the neuromuscular junction to then talk to the skeletal muscles. So you have conscious control. And how do we learn that control? We learn how full our bladder is. When do we need to use the restroom? You get more defined neuromuscular junction interaction as you age, and we would refer to this as toilet training. It's not something you're born knowing. I think this is a nice image. You can see the internal urethral sphincters here. Remember, these are smooth muscle. And then you can see the external urethral sphincters here. And remember, these are skeletal. So these are involuntary. They're controlled by your autonomic nervous system. And these are voluntary. They're controlled by your somatic nervous system. So usually in class, I talk about the fact that after surgery, after you've had anesthesia, they want to make sure that you can urinate before you can go home. They really just want to make sure that both of your divisions of your nervous system are working here, and that you have the ability to relax your smooth muscle, and you have the ability to relax your skeletal muscle, and that you can actually void your bladder, and then they'll send you home. The other thing to look at, since this is the female urethra, when we look at the male, you'll see that the urethra is much longer in the male. And from the reproduction chapter, we know that there's several sections of the male urethra. So you can see this is a really short urethra. So this is why it's easy for bacterial infections, or easier for bacterial infections to happen in females. Not as far a journey for that bacteria. Again, here's the male, same setup. You can see the bladder. You can see the different sections of the urethra that we talked about. They also have internal urethral sphincters at the base of the bladder. And then we have the external urethral sphincters in that membranous layer. And remember, that's where those bulbourethral glands are located. They actually sit real close to the external urethral sphincter. Sometimes you can have a buildup of minerals, usually calcium derivatives, and these renal calculi, better known as kidney stones, can block kidney function. So if you don't have enough fluid, so if you're dehydrated, reduced urinary flow, if you have lots of urinary tract infections, if you have some sort of high level of mineral or chemical, some stones don't cause any problems at all. Larger ones, they can obstruct the kidney, they can block the renal pelvis, they can get stuck in the ureter, which is supposedly very, very painful, and sometimes they can pass on their own. Other times you're going to have to do lithotripsy, which is like a shock wave that breaks those calcium crystallized deposits up into smaller pieces that are easier to pass. This is the term that we use, micturition, to talk about the expulsion of urine from the bladder. Most of us are going to say urine output or, voiding urine, but this is the technical term. And there are two reflexes that are associated. We have a storage reflex as the bladder is filling, and then we have this micturition reflex as we're releasing the urine from the bladder. And again, this is controlled by autonomic nervous system. We have sympathetic and parasympathetic. And hopefully we're thinking automatically sympathetic is going to reduce urine output and sympathetic is going to increase urine output. So here we have the storage reflex, and they're trying to show you here in purple that this is the sympathetic. Remember, this is autonomic nervous system is sending signals to your bladder as it's filling. So it's telling the muscles of the bladder to stay relaxed, detrusor muscle. It's telling the internals to stay contracted as the bladder fills. That should make sense, right? Because if the sphincters are open, urine's going to leak out. And then here we have the somatic nervous system, and you can see from the cerebral cortex, we're sending message. It's synapsing in the sacral part of the spinal cord, and it's sending a message to keep the external urethral sphincters contracted. So everybody is contracted as the bladder is filling up. And then we can see here when we're ready to void, once we are getting close to full in the bladder, we're going to have here in blue sensory input. So basically those baroreceptors are triggering the micturition center, which is the pons, and that is saying, hey, the bladder's full, we have to go. We still have contracted internal and we still have contracted external urethral sphincters. When it's finally time to release the urine, you make it to the bathroom and you're ready to go, you're going to see that there's going to be parasympathetic control, and that parasympathetic is going to tell the detrusor muscle and the internal urethral sphincters to open and cause you to contract or push down on the bladder, contract the bladder muscle wall. Then we're going to see in red, that's the somatic, and that's going to the external urethral sphincters and telling them to relax, and then urine is able to leave the bladder. This is in words what we just looked at. So as the volume of urine in the bladder reaches a certain level, the baroreceptors, those are stretch receptors, right? We saw those in carotid artery. Those are going to be activated in the bladder wall. That's going to send a message to the micturition center in the pons. That's going to send a signal down the spinal cord, and that's going to cause parasympathetic stimulation, which causes the detrusor muscles in the bladder to contract, causes the internal urethral muscle to relax, and then you're also going to have the somatic part where you're telling your skeletal muscles to talk to your external urethral sphincters and telling them to relax. We already talked a little bit about UTIs, or urinary tract infections. We said more frequent in women because of the shorter urethra. It's when bacteria or fungi are multiplying within the urinary tract. It can happen in the urethra, in the bladder, in the ureters. It could move up to the kidneys, which we would not want. Inflammation of the nephron, you can kind of see the word there. Painful urination, frequent urination, pressure, pain. We're usually going to diagnose it through urinalysis. They're going to do a culture and then treat with antibiotics. Last slide here, we can talk about impaired urination. So incontinence, you're unable to control urination. So imagine childbirth, pressure, the weight of the fetus. It could have damaged the urethra. It could have damaged internal, external urethral sphincters. Could be the result of medications. Retention, failure to eliminate urine. So we talked about general anesthesia. Sometimes you have to go, but you can't go. You have to kind of wait for those nerve messages, both autonomic and somatic, to kind of catch up to those sphincters to allow them to relax. Also in males, an enlarged prostate. Remember that prostatic urethra section. If your prostate enlarges, it can narrow that section of urethra, and then urine's not going to be able to escape, and your bladder's going to fill unwanted, right? You're going to back up urine into the bladder. And one of the things to think about this is, okay, so what, I can't urinate. Well, what's going to happen is that bladder is going to fill, and then it's going to tear, and then you're going to be leaking urine into the pelvic cavity. So a catheter is really the only way to correct that issue. Also some drugs. They don't talk about medications here in retention, but I knew somebody that was on a cruise ship, and she was on scopolamine patch, seasickness, motion sickness. And she was on the cruise for several days, and she wore the patch, and all of a sudden she couldn't go to the restroom. She could not relieve the urine. She had the pressure, the pain. Her brain was saying, yes, you need to void the urine, but she couldn't physically make it happen. So catheter is really the only choice to get the urine in or out if this system isn't working. So that's it for this lecture. I hope you guys enjoyed it, and I'll talk to you again soon. Bye.